Hello and welcome to the topic Approach to Hypertensive Emergencies in the Internal Medicine module. By the end of this session, you should be able to define hypertensive emergencies, recall the cause of hypertensive emergencies, describe the presentation of hypertensive emergencies, and summarize the management of hypertensive emergencies. Let's get started. Hypertensive emergency is defined as severely elevated blood pressure associated with new or progressive target organ dysfunction. Although the absolute value of the blood pressure is not as important as the presence of end organ damage, the systolic blood pressure is usually more than 180 millimeters mercury and or the diastolic is more than 120 millimeters mercury. There are many causes to hypertensive emergencies, but let's look at the common ones. We have essential hypertension that is either undiagnosed or inadequately treated, which is a common cause of hypertensive emergency. Another common cause would be systemic disorders or resistant hypertension. Here, you may want to consider other systems that can lead to a hypertensive state. These include renal diseases such as one having renal artery stenosis, acute glomerular nephritis, collagen vascular diseases, or those who have underwent kidney transplants. Next, neurological disorders, following a head trauma or one with spinal cord injury or autonomic dysfunction. How about respiratory diseases? One common cause would be obstructive sleep apnea. Now, this leads to hypertension. Immunological problems such as scleroderma and vasculitis, and not forgetting one of the commonest giant, which is the endocrine pathologies. These include primary and aldosteronism, pheochromocytoma, thyroid disorders, Cushing's syndrome, acromegaly, hyperparathyroidism, carcinoid tumor, or renin-secreting tumors. Not forgetting pregnancy-related disorders such as preeclampsia or HELLP syndrome, which stands for hemolysis, elevated liver enzymes, and low platelets, and of course a state of eclampsia, which are all important causes of hypertensive emergency in a pregnant woman. Last but not least, not forgetting lifestyle choices as well as medications which can precipitate a state of hypertension. These include intake of non-steroidal anti-inflammatory drugs and herbal supplements. Let's quickly take a look at the pathophysiology of hypertensive crisis. So the factors that lead to the development of hypertensive emergency are actually poorly understood. But what is certain is that there is a failure of normal autoregulatory function which combines with the humoral vasoconstrictor increase, and this then leads to an increase in systemic vascular resistance. When this happens, it eventually leads to the increased blood pressure, which generates mechanical stress and endothelial injury, and this further propagates inflammation within the vessels, which then results in ischemia and release of additional vasoactive mediators. Now, these vasoactive mediators generate ongoing injury, which then triggers the renin-angiotensin system, which leads to systemic vasoconstriction and decreased blood flow to the vital organs, which then exposes one to increase in pressure and develops hypertensive emergency. So the key to diagnosis of hypertensive emergency is a rapid but thorough evaluation. The main areas of focus should be the neurological, cardiovascular, and the renal systems. Emergency treatment should be initiated while conducting a full diagnostic appraisal. So when you're looking at neurological compromise, look for symptoms such as blurry vision, dizziness, headache, seizures, any change in mental status from baseline. loss of sensation or paresthesia or loss of movement. Cardiac compromise would include chest pain, shortness of breath, diaphoresis, orthopnea, paroxysmal nocturnal dyspnea, palpitations or edema. And finally, renal compromise, and this relates to the decrease in urine output, which signifies kidney injury. An appropriately sized cuff should be used for blood pressure readings so that the bladder encircles 80% of the arm. The arm should be supported at heart level during recordings, and using a too large cuff could result in an underestimation of the blood pressure. The BP readings should be taken from both arms and readings repeated after 5 minutes to confirm. If there is a more than 20 millimeters mercury difference between the pressure of these two arms, aortic dissection should be considered. A fundoscopic examination should be performed looking for the presence of arteriolar spasms, retinal edema, retinal hemorrhages, papilloedema, and engorged retinal veins. A rapid bedside neurological screen is also required to test cognition, cranial nerve function, dysarthria, motor strength, any gross sensory dysfunction, upper extremity pronator drift, and of course not forgetting the gait. Last but not least, the cardiopulmonary status, examining in particular for the presence of new murmurs, friction rubs, additional heart sounds, lateral displacement of the apex beat, and jugular venous distension. Let's look at the presentation of hypertensive emergencies in lab tests as well as imaging studies. So here, the importance of conducting a lab test is to look for the potential complications of the condition. Urine analysis is done in search for proteinuria and hematuria. This might indicate an underlying renal disease. Blood tests that can be done include a basic metabolic panel, full blood count, or a peripheral blood screen in the case of hemolytic anemia, and other special tests which include cardiac enzymes to look for cardiac instability, urine drug screen, plasma renin activity, aldosterone levels, a spot urine or plasma-free metanephrine levels after consulting the endocrinology team, thyroid function tests, and also a 24-hour urinary free cortisol to screen for Cushing's. How about functional studies and imaging tests? These include ECGs and chest x-rays. A thoracic CT would be important if you are suspecting any cardiac pathology such as aortic dysfunction. A transesophageal echocardiogram is also indicated in a case where a CTPA or CT angiography cannot be done. You may also consider renal angiography for renal artery stenosis, renal ultrasound and Doppler for renal arteries, and a non-contrasted CT scan or MRI imaging, which may assist with the diagnosis of any neurological problems. When it comes to management of hypertensive emergencies, admit the patient for close or continuous monitoring of blood pressure, monitor for target organ damage, and administer parenteral administration of therapeutic drugs. Remember, oral therapy may be considered later as you will require an excessive reduction in blood pressure in the initial phase. There are some exceptions to the above recommendations which I've mentioned, and these include patients with an ischemic stroke where there is no clear evidence from clinical trials to support the use of immediate antihypertensive therapy, patients who are candidates for thrombolytic therapy, typically those with ischemic stroke who should have their BP slowly lowered to systolic less than 185 and diastolic less than 110 before intravenous tissue plasminogen activator is initiated. Patients with severe preeclampsia, eclampsia or pheochromocytoma crisis, in whom systolic BP should be reduced to less than 140 in the first hour. And take note, patients with aortic dissection, which you may come across, in whom accepted practice is reduction of systolic BP to less than 120 in the first 20 minutes. There is an approach to possible hypertensive emergency. So there are conditions that are associated with high blood pressure, and these include pregnancy, aortic dissection, type 1 myocardial infarction, maybe a stroke or scleroderma renal crisis or pheochromocytoma. If these conditions are present, then you may want to look for criteria that meet hypertensive emergencies, where there is presence of target organ damage and severe hypertension. If it is present, immediately control the blood pressure using parenteral antihypertensives. However, if these specific conditions are not present, you may then want to evaluate and treat using specific strategies unique to the underlying condition. Let's look at disease-specific recommendations. So for acute ischemic stroke, treat when the blood pressure is more than 220 systolic over 120 diastolic, with exception with thrombolytics given as long as the blood pressure is above 185 over 110. For intracranial hemorrhage, treat the blood pressure to target at a mean arterial pressure of 130 because a significant drop in blood pressure may increase mortality. As for subarachnoid hemorrhage, keep the systolic blood pressure less than 160. To maintain cerebral perfusion pressure, always ensure that it is also above 120. And for hypertensive encephalopathy, decrease the blood pressure, which is the mean arterial pressure, by 15 to 20% in the first 24 hours. So any aggressive blood pressure drop may produce ischemia. Now let's summarize. Hypertensive emergency is a state of an acute marked elevation in blood pressure that is associated with signs of target organ damage. These can include pulmonary edema, cardiac ischemia, neurological deficits, acute renal failure, aortic dissection, and eclampsia. If the patient has acute worsening of organ function, then the blood pressure needs to be decreased aggressively. In all other cases, the blood pressure should be lowered gradually to prevent further dysfunction of the brain from low cerebral perfusion. Well, we have come to the end of this lesson. Thank you for your time.